Okay, so one of my jobs, I've got several jobs, but one of them at the moment is as a co-chair of the National Children and Young People's Health Outcomes Forum and Strategy. So this is a national group that's been commissioned by, I'll tell you who by in a second, but essentially it's trying to develop a children and young people's strategy for the NHS. So I've been asked to co-chair that. That's not just for cancer, that's for all children and young people's healthcare. And part of that is about developing outcomes and outcome measures. So I'm going to explain that to you in the next 15 minutes or so and tell you what we're doing and provide you with quite a lot of reassurance about the work you've just done, actually, which I think is fantastic. And so who knows these two people? So who knows the person on your left? If you do, put your hand up. Yeah. All right. There'll be an age split. No, but you would be able to say who he was. All right. Okay. So, and who knows the person on your right-hand side? One. Very good. Two. Go on, tell us. Pardon? Ian Kennedy. Yeah. Ian Kennedy. Yeah. So Sir Ian Kennedy. So the kind of context for this work is that Andrew Lansley is the Secretary. You can all boo. Is the Secretary of State for Health. And when the Conservative government came to power, he very rapidly produced a document called Equity and Excellence, which has turned into the Health and Social Care Bill, which is quite controversial for a variety of reasons, but was passed in earlier this spring. And it's him that's commissioned me to do the work, not as an independent group. So we're an independent group doing this work on behalf of the NHS. And he's done it because he accepted the report that was undertaken by Sir Ian Kennedy. So you might, how many of you remember the Bristol Heart report? Some of you will and some won't, all right? But most of you, I hope, do. There was a kind of scandal around heart treatment. Ian Kennedy chaired the Bristol Heart Review. He's a professor of law and ethics at King's College. And he was commissioned actually by the last Labour government to do a report into children's healthcare, which was published after the government's changed. So, but the report by Ian Kennedy was quite hard-hitting. And what Andrew Lansley has said is we accept that report. We accept the diagnostic of the report, i.e. what the report says. We don't necessarily accept the solutions. So, and I'm going to tell you a bit about that as well. What Andrew Lansley has done in the health and social care bill, which has been quite controversial, is a number of different things. So the controversial bits was we're going to privatise everything. That wasn't quite what it said, but that was it. We're moving the commissioning of things to GPs, so GPs take over the money, or a large part of the money. But actually probably, and we're going to take £20 billion out of the health service over 5 years, which is the situation that we're in currently. So there's quite a significant financial strain within the health service currently. But actually, there were two really important things that he did. One was saying we've got to put the patient at the centre. So there was a whole thing about no decision about me without me. Right? And of course, quite a lot of what you talked about here in your discussions today was about that. And the other thing was to say we shouldn't be about targets, process targets, about how quickly we see people, although that is more than a process target, I would argue, but or about how many bits of widgets we can do. It's about what the effect of doing them is. It's about what the outcomes are. So he promoted the development of outcomes frameworks, that is, outcomes, and particularly outcomes that matter to patients and to the public. So although I think you can argue with his politics, and I do, and you can argue with the kind of perspective they've put on it, and some of the issues that are happening around the health service, actually some of the principles around developing outcomes I think are excellent, and some of the principle around patient voice here is also absolutely excellent. You know, it is what we need and what the health service hasn't provided. And so that's a kind of backdrop to this. Ian Kennedy's report, which was published, said a number of things. All right. So, sorry, this slide came first. So what Andrew Lansley said in January, he announced the development of the Children and People's Health Outcomes Strategy, and he asked us to do three key outputs. So the first of those are what are the health outcomes that matter most for children and young people nationally, and this is with all healthcare. The next is how well are they supported by the Outcomes Framework, and I'll explain about the Outcomes Frameworks in a minute. And then he's also asked us, and I'm not addressing this today, but it is part of my report that's going to him in 2 weeks' time, is how the parts of the new NHS will work, or the health system will work, in order to deliver the outcomes. So we're making, and this is for children and young people. So it isn't about bone cancer, but of course, most people that get bone cancer, or relatively so, are young people. You know? He also said that children and young people could be up to age 24, which pleased me because, of course, most of my professional career has been working with teenagers and young adults up to the age of 24. So it's not just about up to 12-year-olds or 13 or 14-year-olds. What the Kennedy report said, what Ian Kennedy said, is that children have poor outcomes and a low priority. And the words that I can increasingly use when I'm talking about this is that in the UK, we're both sentimental about children. We have children in need. We have lots of charities that do stuff. But we're also complacent. We're very complacent about the results that we get with our care. And that's quite hard when you're sitting in the UK and you've got no choice about what kind of care you get. But our outcomes in comparison with other people aren't very good. And I'll come back and show you that. And he gave a group of issues that he wanted to raise as part of his report. And these are some of the key ones. So this is about children and young people's healthcare, not about cancer, but it could equally well apply. He said GPs have little or no formal paediatric training, that caring for children and GPs is relatively low on their priorities because they're not funded particularly for doing children's things. Most of the special funding that GPs get relate to long-term conditions in adults. There's a lack of coordination for children's services, and services don't work together. There are wide variations in care. There's a need for improved data and information, that services aren't configured properly and networks don't work. People don't, even where they're designed to work, they don't work because professionals don't necessarily work within the networks. There's a need to improve workforce competence for children, and there's a need to promote positive health, i.e. to prevent ill health. So this will be quite shocking to you, but it's going on the front of the report. And this is mortality in childhood. This is all mortality up to the age of 18. The big black line is the UK, and the other lines are all the other main Western European countries. And this is from 1986 through to 2007. So this is Public Health Observatory data, Joe. Why are you asking? It's from Helen. But it's done on a European 12 basis. You can argue about whether the data is accurate or not, but it's about as accurate as we can currently get. And what it shows essentially is that for all childhood mortality, that's 0 to 19, up until the mid-late 90s, the UK was in the middle of the pack, and we continue to improve our mortality in childhood, but what we haven't done is improve as fast as everyone else. So nearly everyone else in Europe is now running ahead of the UK. And if this doesn't disturb us, then it should do. You know? This is the reason why children need some kind of priority. All right? So we've been quite happily looking, saying we're getting better, but what we're not doing is getting better as quickly as other people. Okay. If you put that into bone cancer terms, then this is the osteosarcoma survival data that was done for me a few years ago now. But essentially what it says is, the yellow line is a survival line here. What it says is that we've not really changed survival in osteosarcoma in the UK for 20 years. And for Ewing sarcoma, we've only slightly changed. We've improved a little bit. So we made lots of improvement in both during the 70s and early 80s, but we've not made massive improvement still, which is one of the reasons I'm passionate about BCRT, because I absolutely think this is part of the drive for getting things better and how we get better. And Craig mentioned this morning the difference between the UK and Germany in one of our trials, where there was a 10% difference in outcome. And there are, we've interpreted that as meaning there were differences in local control. But we're still not sure if that's completely right, but that is how we interpreted it. But the blue line are the German patients, the red line are the UK patients treated in the same clinical trial with a difference in survival. I realise this isn't very cheerful, but it's kind of the backdrop against why we need to improve things. Other children's things that you might just be interested in, so other than bone cancer, is that if you take meningococcal disease, you all know about meningitis, meningococcal meningitis. Many of you will know about it. It's a really deadly form of meningitis that affects children. That when they've been reviewed, half of children are found to have been sent home with their first primary care consultation before they're readmitted. And lots of children with asthma could be treated better in primary care. So this is about whole pathway. and one third of short stay admissions could have been treated in the community. So we're not doing very well, we're sending a lot of children into hospital that probably don't need to be sent into hospital. I seem to be majoring on general practice, but actually I'm not. I think other people, when Andrew talked this morning, he talked about delay happening in secondary care as well, I think. But some of the focus, because most contacts for children are in general practice, they're not in hospital. You know, if you think about your contact with your children, apart from when you're ill, you know, when you're ill and you end up in hospital on a pathway, the vast majority of your contacts are with general practice. So how general practice works for children is absolutely key for the health of children in this country. And what this is a variation chart. So each one of these bars represents a general practice within a particular area. As it happened, it was Leeds several years ago, but it doesn't change. That's because I was working there at the time. And at this end, this is the number of attendances in a 6-month period for young people under the age of 19. And what we've got is a 6-fold variation between the bottom end and the top end, from one practice to another. All right? So in some practices, you're 6 more likely to end up in the emergency department than if you're treated in another. Now, what's the right answer? I don't know. All right? I'm not saying there is a right answer. All we're saying is that there is massive variation. All right? Now, everyone said when we did this work, actually, the people at this end will all be the most deprived and poorest families. And they'll be well off at that end, and that's what it is. But it isn't that at all. So when you look at the practices, those practices where people turn up a lot and turn up little can be completely overplayed in geographical terms and with the same social thing. It's dependent on the practice, not dependent on the geography. There is a very slight, I have to be fair, not least of which because I've got an epidemiologist sat in the front row, and so when you do look at deprivation, you know, at kind of measures of poverty or deprivation, then there is a slight shift. So that people who come from slightly more deprived areas and closer to hospitals are more likely to use the A&E department. But that isn't the major factor that's involved. The other thing is that nationally, this is a shocking thing for me. This was in Ian Kennedy's report. Less than half of GPs get any formal paediatric training. And we've got very patchy community nursing teams. So whoever was talking about palliative care, who was that? Was that you, Sue, near the end? About end-of-life care? And about how patchy it was? All right. Well, some of that is because we have completely patchy children's nursing teams who support palliative care. So some areas we have almost no children's community nursing team, others we've got full, very few now, but we've got 24/7 community nursing teams to support that kind of process. So that's some of the data around children, and part of the reason why the Children's Outcomes Framework is the first specialist outcomes framework that Andrew Lansley has announced. It's because some of this data causes them quite a lot of concerns. So the NHS Outcomes Framework, which is what we're supposed to fit into, is organised around 5 domains, they're called. Okay? And they're a bit technical, but it's important just to understand them. It's about how we define what some of them are. And essentially, there are kind of 3 groups of outcomes that people talk about. So we talk about being clinically effective, that is the treatment that you're giving effective for the patients? And there are 3 domains that concern with those. So domain 1 is preventing people from dying prematurely. That's the survival bit. And actually it's the indicator that people use is mortality that's amenable to healthcare, i.e. things that you can make a difference about. The domain 2 is enhancing quality of life for people with long-term conditions. So for people with, and that includes cancer, but it also includes diabetes, asthma, range of others. So it's trying to improve quality of life for people with long-term conditions, and some of that is through hospitalisation. Domain 3 is helping people to recover from ill health or following injury. So that's like acute illness, really. Yeah. And then there's a domain that's about positive experience of care or patient experience. Okay. And there's a 5th domain, which is safety, so treating and caring for people in a safe environment. So those are the 5 NHS domains. And there are some indicators that are in there already. So the NHS Outcomes Framework was published in December 2010. It's been updated earlier this year. But there are relatively few outcome indicators. All right? So the outcome is that side. We're preventing people from dying prematurely. What you then have is a series of indicators. That is, how do you measure whether people aren't dying prematurely? because it sounds easy, but it's actually quite tough to decide on what the indicator is for that. And we don't think these are particularly good, but these are the ones that are currently there. Right? So for children, there are others for each of these for adults. There are quite a lot for other people. But for people for preventing people from dying prematurely, the ones that are in there already are infant and neonatal mortality. So it's only in that very small first bit of life. Very important. For enhancing quality of life for people with long-term conditions, there's for children, there's unplanned hospitalisation for 3 common chronic conditions. And the reason that's there is that if you're managing a chronic condition properly, you shouldn't end up suddenly going to hospital. You know, that's why that's there. You know, you shouldn't have acute getting worse asthma or acute getting worse epilepsy. You should be managed in the community, you should have control. So it's a measure of poor management. For acute illness, it's emergency admissions for infection, chest infections. LRT are lower respiratory tract infections or chest infection. And that's because chest infections, mostly in children, can be managed at home and in the community, but a lot are admitted into hospital. Positive experience of care is about a patient survey, as was your experience good? At the moment, it's only outpatients. And treating in a safe environment for children is harm due to failure to monitor in hospital. That is to try and, that's because some children deteriorate suddenly in an unexpected way in hospital, and they're on a ward and no one knows, and you end up with blue lights and lots of people running around to stop people having cardiac arrest. And so when you measure that number, you can try and reduce it. So these are all areas to be improved. So what we were asked was, in addition to those, what are the outcomes that matter to children and young people and their families? And what are the indicators that might tell us that? And the reason for that is that so that we can regularly report in order to compare centres, to compare doctors, and to compare countries. So it tells us where we are and starts to tell us how we might make change, because it will help drive improvement. If you know what you're doing, then you can start to think about how you do it better. But quite a lot of things we don't know what we're doing. To provide information and help families choose, so that was very high up on your list, right, of giving you information. And to provoke and inform research, because if you don't look at that first graph and say, we've got to understand why that's happening, then you're not a researcher. You know, you might look at it and go, but actually, for anyone who's interested in improving outcomes, you look at that and you go, we've got to understand why that's happening, and we've got to develop interventions to change that. So these are the things that I thought you might say this afternoon. All right? And some of them are right and some of them are wrong. All right? You know, this was my prediction based on other things that people have said to us in the past. All right? And I did these at 12:30 last night. So because I was trying to think, how do I do this bit when you've already done it? So I thought, I know, I'm just going to put them on a bit of paper and see how we get on. All right? So the ones that I thought might come through, and some have and some we've got other things as well, is survival getting better, as little or no disability as possible, living a normal life, whether that's undertaking education, work, family, with as little disruption as possible, having children, that didn't come through today, interestingly, having as rapid a diagnosis as possible, best chance of getting better in the world, information that enables you to make choices, and not having to repeat yourself to every new person you meet, because that came over really strongly in our other things that we've done. And the methodology that we've used for determining the outcomes that matter most to children and young people isn't the one you did today. We've taken a medical pathway. This is a classic medical pathway, very medical. Anyone who looks at this and goes, that isn't medical, doesn't understand. So when we talk about a pathway, we say the first thing is to prevent illness, prevention, health promotion. Then people present with a problem, you know, I've got pain in my arm or leg. Okay? Then you try and find where you go with that. And then having got that, you hope you're getting an assessment and a diagnosis. And then you have a discussion about what that might be. You know, there's nothing wrong with you bog off and come back and you go back 5 times, or actually you've got a tumour, you need a, you know, any of those, but it's a discussion about what the options are. Then you get some interventions, and those can be short-term interventions or long-term interventions, and they might end up in end-of-life care. And then for some you get off-treatment, follow-up and discharge, and then you're back into how do you stop having more problems. Right, that's the kind of classic medical pathway. What we've done is to turn those into a whole series of questions. I don't know if you can read it, but based on the discussions that we've had, These are questions that have come from children, young people and families. So how do I stay healthy? How do I stay out of hospital? Because if you start to ask a question, what you get is an answer. And the answer gives you an indication of what the outcome might be in the indicator. Does that make sense? So if I ask you, how do I stay healthy and how do I stay out of hospital? You start to come up with some answers. All right? I stay healthy because someone tells me what I need to do, what immunisations I might need, you know, how I stop getting sexually transmitted disease if I'm a teenager, you know, how I don't get cancer when I'm older if I don't smoke, you know, any of those things. I have a problem, can you help me, how quickly? What's wrong with me, how quickly can I find out? Am I in the right place? Are you the best person for me to see? Does all this make sense? I need clear and accurate information delivered with empathy. Can you help me decide what's best and what choices I have? Yeah. I want best treatment. How do I know I'm getting it? How does it compare with elsewhere? What are the effects of treatment? Is my treatment safe is one. Actually, it's another one. It's got lost up here. How do I maintain normality? How do I stop myself getting worse? How does it affect my living? Do I need to watch out for anything, and so on? Okay. So we've taken that question approach and then applied it across a wide range of conditions to come up with a series of answers. And I can't tell you them all because we haven't yet told the Secretary of State. And I can tell you some. Right? These aren't them. These are just examples of things that might be indicators as to how the health service is behaving. So these are very high level. And one of the big problems we've got is there are hundreds of children's conditions. Actually, there are thousands of different conditions in children. And what we've not done is to come up with indicators for each one. We can't do that. That's the job of specialist groups like this. Right? What we can do is to say these are generic indicators that help us determine how the health service is working and how you can start to compare what's happening, right, to use it. So things like immunisation rates are very obvious, you know, big or little, how well people are immunised. Out of hours attendance at an emergency department is a way of measuring how your acute service is working with your general practice. You know, if your general practice runs an out of hours service and it's effective, you see very low rates of attendance at emergency departments. If it's ineffective and you don't know who the hell to ring, you go to your emergency department. That is what happens. Right? It's quite a good indicator of what happens. Okay. Time to diagnosis, experience in patient infections. You can see where some of those are going. All right. So we've taken quite a lot of feedback. We've had, we were on the DH website, including people from BCRT have fed back. We've had lots of feedback, over 1,000 individual bits of feedback. We've done web chats, we've done all kinds of other stuff about it. And children and young people have told us these things, that they want better access to child-friendly information, care by professionals who've got training in children and young people, to be in environments which are appropriate for their age and needs, appropriate and efficient system of transfer from childhood to adult services, transition. And they want to have a say and be listened to in decisions about their health and take a lead where they're able. The issues that they've identified for us are lack of join up around health, social care and education, poor and delayed diagnosis. This is for a range of conditions, not just cancer. This is for everything. That general practice doesn't meet their needs, that outcomes need to take a whole family approach because of health and well-being, and that outcomes need to be included for different ages, i.e. babies aren't the same as teenagers. And transition is very disjointed. So we've developed a range of outcomes, and these are some of the recommendations that we're making. We had this generic versus condition specific, i.e. it's difficult to do every condition, so we've made generic. What we said is that all indicators reflect life cycle. So by that we can divide people up into, you know, we're looking at small babies, school children, teenagers and young adults, rather than 0 to 24, which is what happens currently, or 0 to 19. Patient experience measures need to be measured in all healthcare settings so that we know what your experience is. And that will influence things like age-appropriate care and teenage units. Age-appropriate care and transition to adult services, internationally comparable outcomes like mortality and this thing for diabetes, I'm not going to go, and safety outcomes. And we've got, I won't do that bit. So some of the key things that we're recommending to be included in the NHS operating framework, and we've only got a few that we can recommend. They're not going to, there's only 66 in it now for everyone. So we're only going to be able to recommend another 4 or 5 new ones. But these are some of the key ones that are going in. So time from presentation at NHS setting to definitive diagnosis for some defined conditions. And that is a real challenge because, as Jill was saying this morning, it means we've got to go back to when people first present in general practice, and we can't do that now. So that is a real challenge for the NHS to try and deliver that. But given that the adult people want to do it as well, I'm quite optimistic that we'll get there. But we might not get it. That gives us the information that everyone always tells us. But it will take 2 or 3 years to get there. And there's also establishment of a care plan. We won't go into that. Cancer mortality in children and young people. Medication errors that reach the patient. Medication errors are the commonest kind of error that happens to people in hospital, in children in hospital. You might not know that, but it happens really frequently. And so we're absolutely focused on reducing those, because everyone says you can't reduce it, but you can. It's just about doing the right things. Emergency readmissions, i.e. discharging people too early, and functional recovery following brain injury. We're looking at quality of life for children with long-term condition and disability. So it's measurement of quality of life. So that will include the kind of things you were talking about. Transition to adult services from childhood. And then 2 relating to school, because school for children and young people is essential, and that came up in some of the groups. So educational attainment and progress, and school absence, because lots of children with long-term conditions miss lots of school, largely because of how we organise the health service. Right? It's poor. There's a real issue there, and we're having a fight with Michael Gove currently, because there is no way of tracking children who have long-term conditions into school and out again. There's no single number that is used, but there is a single number that's used in the health service, which is the NHS number. So one recommendation that goes along with this is that we use the NHS number in schools. But believe me, that is so politically sensitive that I'm probably going to get shot as I walk out the door. So, there are some priorities in bone cancer that we need to do to improve outcomes. We need to improve the time to diagnosis. We need to improve survival. We need to improve collaboration around trials. And we need to promote some of the research that Baz was talking about earlier. Optimistic and focused is a kind of outcome. It's a process, isn't it? I guess we heard about that from Alex early on. But I hope what that's done is to set the work that you've done, because it was really helpful, and I'm going to use it as well, in the kind of national context of what we're doing. Thanks very much.